and the chronic phase in which you have to correct the lid and the adnexal problems, ocular surface stabilizing procedures are required, and of course the bottom line is that the patient wants some vision, so visual rehabilitation is important. Amongst the chemical injuries, acid injuries, they tend to cause less damage because the protein coagulation limits the penetration, and various acids can cause injuries. And amongst the alkali injury, the tuna packet injury in our country is extremely important, especially in children, and it causes more damage because of the saponification and the liquefactive necrosis. This is the study that we published, and subsequently we have also published a larger study of this in ophthalmology. Notice that the age of the children with the tuna packet injury that reported to our center is 8.4 years, so all of them were children, and grade 4 injuries were present in more than 95% of the cases, and only 8 out of these 25 were corrected on medical therapy, but for rest all of them we had to do surgery, and the surgery does have a very poor visual prognosis, whether you do stem cell or whether you do grafts in these cases, which normally doesn't take up. This was the paper that we published in ophthalmology. Now, if you see, as soon as a case of chemical injury comes in, it is important to look at the conjunctiva for any hyperemia, chemosis, epithelial defect may be there may be stromal haze, then there could be perilimbal ischemia. Very important to see and inspect the fornices for any residual matter or any chemical that may be present, which should be removed. And apart from this, there can be decrease in the best corrected visual acuity due to epithelial defects or stromal haze. Also, there could be corneal perforation, there could be AC reaction, increase in the intraocular pressure and the adnexal change. And initially, we classified chemical injuries based on the Roper-Hall classification, grade 1 to grade 4, on limbal ischemia and corneal involvement. But now, according to Dua's classification, he has reclassified grade 4 into 4, 5 and 6, because with the advent of the newer techniques and technology, the prognosis in the grade 4 has improved. So immediate management consists of the irrigation of the superior and inferior cul-de-sacs with saline, ringalactate, BSS+, and even if you have nothing, then just but with plain water. The idea is that irrigation is the most important step in a case of acute chemical injury. It could be just plain water, plain filtered water, or plain RO water, but irrigation is very important. Then remove the foreign bodies, because you need to remove the depot for chemical, and the pH should be tested, which should be maintained at 7 to 7.3. The management strategies consist of promoting epithelialization, supporting repair, minimizing ulceration and controlling inflammation. And in the early acute phase, the management consists of use of preservative-free artificial tears 2 hourly, antibiotic to prevent infection, QID doses, prednisolone 1% 2 hourly, ascorbate and citrate 10% in the same frequency, acetyl cysteine 10 to 20% QID, autologous serum, especially if the defect doesn't heal. Oral vitamin C has a role because that helps in repair, and cycloplegics and anti-glaucoma medication if required. Apart from this, these are the experimental, these are the things which have been tried experimentally to promote epithelialization. And steroids are given in the initial first 3 weeks because they reduce the inflammatory cell infiltration, and medroxyprogesterone also may be given during the same time. Now, autologous serum is given in cases where the epithelial defect is there, mainly because it has concentration and biochemical properties which is very much akin to human tears. And we did this study where we compared cod serum with autologous serum, and we mainly did this because cod serum has various growth factors which are in higher concentration as compared to the autologous serum. And it is done, cod serum was obtained using a standard technique that has been already described in literature, and we found that the patients in which cod serum was used as opposed to autologous serum or artificial tears did better, and this was found to be significant. This is one of our cases in the cod serum group which healed, another case in the autologous serum which again healed, and the artificial tear group which did not heal. Apart from this, there are newer modalities such as amnion extract, topical Avastin and ACE which have been tried, and if you have nothing actually in the acute phase itself, if there is no tissue available and there is a perforation, you can even do tenoplasty or conjunctival flap. The idea is just to cover the globe and do tarsography and use adhesives if and when required. Amniotic membrane transplantation has a role to play in acute burns, and we from our center did 2 studies where we compared it. We studied the role of amniotic membrane transplantation in randomized control trials in grade 2 to grade 4 burns, And we again found amniotic membrane transplantation to be helpful in these cases in terms of decreasing the acute symptoms, not so much for the chronic sequelae. Coming to the chronic burns consists of management of the lid abnormalities, any surface abnormalities by limbal stem cell transplantation or by COMET procedure if it is a bilateral case, and then you may require visual rehabilitation using lamellar grafts or penetrating keratoplasty grafts subsequently. In a case of unilateral stem cell deficiency, what is advocated is the amniotic membrane transplantation alone, so that there would be in vivo proliferation of the stem cells which are present on the surface, and the stem cells are taken from the fellow eye. However, in case of a bilateral stem cell deficiency, because you cannot use the fellow eye, so you use other sources of stem cells, and in these cases COMET has a role to play, and there are other techniques which have also been described, such as live-related techniques which can be done are live-related stem cells. Two of our cases where live-related stem cells was done, and the only disadvantage is that you have to give systemic immunosuppression for at least 1 year in these cases. We've also done cadaveric limbal stem cell transplant, 2 of our cases, and again systemic immunosuppression was needed in this case. Another technique which has been described is a keratolimbal graft, where you include some of the stem cells already in a penetrating graft, such as in this. So you cut the graft eccentrically to include the limbus, but again systemic immunosuppression is required. We described a technique of large diameter lamellar keratoplasty and reported our results, and post-op best corrected visual acuity was 6 by 60, better than 6 by 60 in most of the cases, and corneal clarity was also good in these cases. The advantage is that in a single step you are transplanting the stem cells as well as giving visual rehabilitation to the patient, and the disadvantage is again that systemic immunosuppression is required. Now, this is just to show how a limbal lenticule biopsy can be taken in these cases from the limbus, from the fellow eye, which is normal, and generally you mark 2 mm by 4 mm, and this can then be harvested using a lamellar dissector or using a crescent blade, taking about 0.5 mm into the clear cornea, and these are then grown on the lab. Alternatively, they can also be when you do a simple limbal stem cell transplantation, you can grow the cells also on the eye itself, and this is the recipient eye from which the pannus is removed first, and after removing the pannus, the cells are then transplanted onto the surface, and these cells have been grown on the amniotic membrane in the lab. The small explants that you see on the amniotic membrane are the cells which have been grown in the lab, and these can be either sutured with the suture, or this can be made to adhere with the fibrin glue. These are the various studies in literature reporting the outcomes of stem cell transplantation, and most of them have reported a success rate of 70 to 80%. In cases where you have bilateral limbal stem cell deficiency, COMET is advocated. That is, instead of the limbus, you take the oral mucosa of the patient, and after removing the pannus, the oral mucosal cells are grown in the laboratory again on the amniotic membrane, and after removing the pannus, the amniotic membrane is then transplanted onto the to the recipient eye. And the results are not as good as which are given by the limbal stem cells, and the explants are bigger because the oral mucosa is a thicker tissue that is taken. And at the end stage, in a case of wet eye, if all else fails, then Boston keratoprosthesis can be done, and in case of dry eye, OKP can be done. And these are the cases that we followed. There were 16 patients, 31 eyes, who actually near Rampur fell into a ditch which had sodium hydroxide as industrial effluent. The whole truck all the laborers were traveling in the truck which fell into that ditch, and we follow these cases prospectively, and these are the outcomes of those cases. And some of them did well, but some of them had to undergo limbal stem cell transplantation, keratolimbal grafts. And this was a useful data because we had so many eyes with one chemical reported to us simultaneously, and we managed them on a long-term basis. Now we have a 4-year follow-up of these cases. Thank you for your attention.